Hello, my name is Abby Hirschman, and welcome to my Comms Talk, where the ultimate goal was to find a better medication for treating binge eating disorder by looking at medications already developed to treat opioid addiction. When something becomes addictive, typically 3 stages are seen. The 3 overall stages are craving prior to engagement in behavior, impaired control over one's behavior, and continued behavior despite adverse consequences. The 3 stages we see in opioid addiction are craving for the influx of opiates, destruction of social connections while attempting to obtain opiates, and continued use of opiates despite a decrease in social connections and quality of life. The 3 stages we see in binge eating disorder are the desire to eat when calories aren't needed, not being able to stop eating, and continuation of binging despite weight gain. The chart on the right side of the screen displays the development of addiction for opioid addiction and binge eating disorder. While both paths of addiction are similar, binge eating does not have an exposure period because eating is a natural and necessary part of survival, and only becomes destructive when it becomes addictive. The blue sections in the middle of the chart point to the brain mechanisms and behaviors that are observable in addicts. The 2 red sections show the current medication types available to treat opioid addiction, where they act on the cycle of addiction for opioid addiction, and where they would act on the cycle of addiction in binge eating disorder. Constance Holden wrote that reward is registered similarly in the brain, regardless of whether it comes from a chemical or an experience. On the right side of the screen, you can see the different brain regions involved in addiction. While there are many structures and multiple neurotransmitters on this figure, I'm going to be focusing today on the mesolimbic pathway and dopamine. The mesolimbic pathway is also known as the reward pathway and is involved in every type of reward, whether it be from a cookie or heroin. The mesolimbic pathway starts in the ventral tegmental area, or VTA, which is a collection of neurons that stretch to the nucleus accumbens. When someone eats a cookie, the neurons in the VTA are stimulated and release dopamine into the nucleus accumbens and the ventral medial prefrontal cortex, or VMPFC. The dopamine released into the nucleus accumbens allows the brain to register the cookie as rewarding. The VMPFC is the region of the brain important in decision making, so when dopamine is released into this region after eating a cookie, it influences the brain's decision to eat more cookies because it registered that first cookie as rewarding. As you can see on the right side of the screen, there are drastically different rates of binge eating disorder, or BED, between men and women. In the brain, there are 3 different types of opioid receptors: mu, kappa, and delta. Today, I am just focusing on the mu receptors because they are the most related to reward. So when someone eats a cookie, not only is dopamine stimulating the nucleus accumbens, but opioids are released and bind to mu receptors which exist all throughout the brain. Different opioid binding capacities of the receptors contribute to differences in the rate of binge eating disorder between men and women, and also contribute to the differences in age. One difference is that women of reproductive age have higher mu opioid receptor concentrations, and so they need a smaller stimulus to get the same reward. So if a 20-year-old man needed 3 cookies to stimulate the receptors, a 20-year-old woman might only need 1. Another factor is that after menopause, the mu opioid receptor concentrations levels fall below those of men. So while a 60-year-old man might still need 3 cookies to stimulate the receptors, a 60-year-old woman might now need 5 cookies. While not much is known about genetic links in binge eating disorder or opioid use disorder, obese individuals with binge eating disorder have been found to share the G+ allele. An allele is an alternative form of a gene that arises from a mutation. In addition, the A118G allele of the mu opioid receptor gene has been found to be overrepresented in people with binge eating compared to obese controls. There is less consensus about genetic links in opioid use disorder, but those struggling with opioid addiction are theorized to share specific types of dopamine receptors, which would influence how reward is encoded in the nucleus accumbens. On the right side of the screen is a close-up of a connection between 2 neurons. The small red circles are the neurotransmitters. The blue section is the neuron releasing the neurotransmitters, and the green section is the neuron that is taking up the neurotransmitters after release. Neurotransmitters are stored inside neurons in vesicles or sacs. So when the neuron is stimulated, the vesicles can bind to the membrane of the neuron and release their neurotransmitters into the gap or synaptic cleft. After release, the neurotransmitters either bind to the next neuron, are degraded by enzymes, or are taken back up into the first neuron to be reused. The three neurotransmitters I'm going to focus on today are serotonin, dopamine, and endogenous opioids. Fluoxetine, an SSRI or selective serotonin reuptake inhibitor, is currently being used to treat binge eating disorder. This medication works by stopping the reuptake of serotonin into the first neuron and therefore keeping more serotonin in the synaptic cleft and resulting in more serotonin binding to the second neuron. This is being used to treat binge eating because an increase in serotonin in the hypothalamus has been shown to decrease food intake. However, this medication has severe side effects, such as weight gain and sexual dysfunction, that many patients find more intolerable than not treating their disorder. Dopamine is necessary in making connections between learned behaviors and reward. Therefore, dopamine is not involved in whether the cookie tastes good, but is involved in the anticipation of the cookie. Recent studies into the role of dopamine in the brain show that dopamine is important in the wanting, motivation, and desire for a cookie, while the endogenous or natural opioids in the brain are what actually makes eating the cookie rewarding. In binge eating, endogenous opioids are released to reward the behavior of excess eating. While this was evolutionarily beneficial to increase fat storage for long-term survival, it is no longer necessary in our society where food is readily available. In orange on this slide are the current treatments for binge eating disorder. In blue are the current treatments for opioid use disorder. In purple is my recommendation for the best treatment for binge eating disorder. Fluoxetine, as described before, increases the amount of serotonin in the synapse, which decreases overall eating, but has side effects such as weight gain and sexual dysfunction. Nalmefene is currently used to treat alcohol use disorder. It is a naltrexone derivative, or opioid antagonist, that is being used to treat binge eating on a case-by-case basis. Opioid antagonists bind to the opioid receptors, blocking the binding of opioids. While this medication was effective in a few people, it has not been studied on a large scale. Topiramate is an anticonvulsant used to treat epilepsy and migraines that is thought to reduce the impulsiveness associated with binge eating disorder. However, it has not been studied enough to determine its effectiveness and to rule out detrimental side effects. Methadone is an opioid agonist that decreases withdrawal symptoms in opioid addicts, but has its own withdrawal symptoms if stopped. Therefore, it is not a realistic treatment for binge eating disorder because it would just give those patients another addiction. Suboxone is a mix of an agonist and antagonist, but could also cause addiction and requires special physician training for prescribing, which would create a barrier to treatment. Vivitrol is an opioid antagonist, but is injected and works for a month at a time, so if the patient reacted badly to the medication, they would have to deal with the side effects for a full month. Contrave is a combination of naltrexone, an opioid antagonist, and bupropion, which blocks the reuptake of norepinephrine and dopamine into the first neuron. In a study of 25 women with binge eating disorder and depression, 83% saw a drastic improvement in binge eating disorder symptoms after taking Contrave. In addition, it is cleared from the body in a day, allowing for quick cessation of use if side effects emerge. I am recommending Contrave because it decreases the pleasure and reward associated with binging, causes an overall reduction in binging behavior, and is a more beneficial treatment for binge eating disorder than the current recommended medications. I would like to end my presentation by thanking everyone that has helped me along the way. I would like to thank Professor Sarah Meertz for being my mentor, keeping me on track, guiding my work, and helping me find a topic that interested me, Professor Larry Wyszynski for answering my many questions about drug functions, and Dr. Michael Aylward for his insight on opioid addiction treatments. In addition, I would like to thank you all for listening to my presentation and look forward to any questions you might have.